Matt Emming began his career in EMS over 30 years ago, working as a volunteer driver, then EMTA for the Newell and Fonda ambulances, and later obtained his EMT intermediate and paramedic certifications while attending college at Western Iowa Tech, Sioux City, before beginning his career positions. Matt has worked as a paramedic for hospital-based services in Spencer and Storm Lake, and also served as the EMS coordinator for Iowa Central Community College. He is a previous Northwestern Area Training Academy, Buena Vista County Emergency Medical Services Training Academy, and an Iowa Emergency Medical Services Association board member, as well as a National Registry representative administering advanced level practical evaluations in both Iowa and Nebraska. Matt actively teaches continuing education classes throughout Iowa and currently serves on the Iowa AHA Mission Lifeline Stroke Task Force. It's my pleasure to welcome Matt Emming.
Oh, thank you very much, Courtney, and welcome everyone to this afternoon's presentation. I know Courtney will be kind of monitoring the chat. I do have it up on the side there. If I catch any questions as they come through, I'll try to answer them. Otherwise, we'll make sure we loop back and cover all of them this afternoon. So with that, I am going to go ahead and get started. Once again, my name is Matt Emming. I'm a paramedic by trade. Mostly working here in the state of Iowa. So all of what we cover today is going to be kind of focused on the system that we have in EMS here in Iowa and how that relates to our stroke patients. Now, this is a national program that we are moving on throughout the other states here. Right now, we've gone through Iowa, Nebraska, and Minnesota, and bringing online South Dakota, Nevada, and Hawaii coming up with this Mission Lifeline process. What I also kind of bring out is obviously these are a training put together by AHA in coordination with our Iowa Stroke Task Force. So once again, this is not meant to supersede any local protocols, regional protocols or guidelines or anything like that. But what I do tell all of our folks that I train, if this makes patient care outcomes better by changes that we come across, then that's good for our patients. And also as far as that goes, I am a contract trainer with AHA doing this for the EMS world. But beyond that, I don't have any other financial relationships to disclose. So with that, we're going to dive into this. The Mission Lifeline Stroke Task Force is a group of EMS providers here in Iowa, funded by the Helmsley Charitable Trust, and working on improving the systems of care that our patients receive. And by that, we've kind of brought EMS into this fold because we are the first contact for a lot of these folks, and how they progress through the care throughout the facilities and onto their final destination is the entire system that we're trying to improve. And we know that there's delays that happen along the way. So if we can address some of those delays and improve the outcomes, that's a golden standard that we all want to achieve. And there's also been a lot of changes over the last several years. There's new therapies for stroke patients that didn't exist when I first started doing EMS. When I first started this 30 some years ago, you had a stroke pre-hospital, we brought you to the emergency room, and what you had is what you had. There wasn't much we could do for that. Along the way, we've introduced IV clot busters, and now we have the capabilities to do the endovascular therapies and actually go in and pull that clot out of there. So we're going to talk about some of those advances that have occurred over the last several years. Once again, since this is an EMS conference or EMS focused topic, here's what we talk about when I'm out doing the training with our different EMS agencies. You know, we talk about the recognition of the stroke, the role that our EMS providers play in this, and then we spend a lot of time talking about a large vessel occlusion. And this is some of the new concepts that are underway here with focus to the EMS that did not exist as little as 5 years ago. The capabilities here in Iowa to do those endovascular and retrieve that large vessel and pull that clot out of there. So we're going to talk about some of that as well. And then we're going to look at the different stroke centers that are in our state and near our state that our patients are going to be transported to. With this, we start with a case study. Our first gentleman here is Mr. Hernandez. He's a 59-year-old Hispanic male who's found seated at the kitchen table. He's slumped to the right and having difficulty speaking. Mrs. Hernandez left about 9 o'clock to go shopping and came back and found him at 9:55 and called EMS. A common question that we run into when we're talking with anybody about this is like, well, I can drive to the hospital faster than I can call 911 and wait for an ambulance to show up because, out in the rural areas of Iowa, we have volunteer services and it takes 10, 15 minutes for them to get there. Now, I would never argue with somebody that they could not drive to a hospital faster. And that's probably true throughout our entire nation. However, where are you going? Just because they see an H, not every hospital can handle every type of presentation. That's where EMS comes into play. When folks call 911, they are getting very highly skilled, highly trained individuals that know the medical system and that know where these patients need to go. Not all hospitals can handle the strokes. Very few can do the endovascular. And if that's where this patient needs to go, any delay is giving them worse outcomes. We also know that if we can get involved right away and get this blood flow restored to the brain quickly, they're going to have a better outcome in 90 days. And that's what we want for our patients. We want them to go home in a better position than what we found them in. And we also know, like I talked about, we understand the destinations. We understand where these patients need to go. They don't necessarily need to go to the closest hospital because that hospital might not be able to treat them. And we're going to talk about some cases down the way here of, hey, this patient might need to go past the local hospital and go to a more advanced level care right away versus stopping locally. Back to our gentleman here, Mr. Hernandez. EMS arrives at 10 o'clock. So we have found the right-sided facial droop and the difficulty speaking is our first presentation. We also notice that he has a left gaze deviation. Now, in the EMS world, that kind of gives us a clue. There's a couple different ways that they can have a stroke. We can have a hemorrhagic stroke or we can have an ischemic stroke. And we're going to talk more about that as we get into this presentation. But we do know this gaze deviation is giving us a clue that they have a large vessel occlusion. Now, it's not 100% highly suggestive of this, but it gives us a pretty good idea that, hey, this patient is going to need some type of clot buster and then go on to an endovascular therapy. Some of the information that we provide, we have a last known well or an LKW time of 9 a.m. So we know that this event has been going on to the best of our abilities about an hour. Mr. Hernandez is alert and oriented to person, place, and time. He is having some difficulty speaking, but he is able to follow all verbal orders. We also notice that he has a complete right-sided deficit with that gaze deviation confirmed. We see the blood pressure of 230 over 118 and a blood glucose of 120 and a sinus rhythm on the monitor. So we know the blood glucose has ruled out hypoglycemia, but we also notice that blood pressure is very high. Now, some of our time, not too long ago, we started adjusting that blood pressure pre-hospital and giving medications. We have now found that that's not the best plan for our EMS folks. So we're going to leave that alone, but we're going to circle back later on of why that blood pressure is just so darn high. As we look at our standard protocols, we do the facial assessment, we do the speech patterns, we do the grip assessments of our patients. We don't necessarily pull out a flip chart and go through the stroke severity scales. However, we also know that at 3 a.m., our assessment is probably a little bit different than it is at 3 p.m. We're not quite as sharp. We might not quite be as untuned to some of these subtle changes. So science has shown and research has shown us that if we have an actual assessment tool, a physical tool to go down, we're going to be more sensitive to some of these things that we might miss. As you can see there, with a tool and with a successful training, that is sensitivity has gone up to 86 to 97%. So that's why we start talking about different stroke assessment tools. The common tools that we have always taught in EMS is our Cincinnati pre-hospital stroke scale. We're looking at the facial droop. We're looking at the arm drift. We're looking at strength. We're looking at leg drift. Those are just looking at the major neurological deficits. They're telling us a yes or a no that this patient has deficits that are consistent with stroke. On the right side of the screen, there are our large vessel screening tools. Now, these are the ones that we talk about getting more specific on. The Cincinnati has limitations. It's going to miss some of these ischemic strokes. where having an LVO tool gets us to grab some of these patients and put them into a better classification. All of those tools out there are large vessel screening tools. None of them have been shown to be any better or worse for EMS inclusion, but the race has been found to be most similar to what EMS is doing already. So if we're already doing those activities, we're more likely to utilize that tool moving forward. Now, why is this important for our EMS population? Because we have the advent of the endovascular therapy or the EVT procedures for those large vessel occlusions. That, once again, did not exist that many years ago. In 2015 or so, the University of Iowa was starting to do some of these trials. In 2018 and 2020, the endovascular has now become a critical component to this care. So as many as 5 years ago, this wasn't part of our stroke care. It is now. But this therapy, as well as the medication, are very time dependent on the last known wells. So that's why we really focus on here in the state of Iowa. We're going to offer the RACE as our primary tool. Now, if they're using one of the other large vessel screening tools, we don't want them to change. We want them to continue to use the tool that's familiar with their system. But if you're not familiar with any of the tools, let's work on RACE. And we're going to go down a RACE assessment here in just a little bit. Actually, here we are right now. So we're going to do that race assessment on Mr. Hernandez. So the first thing we're going to assess is the facial palsy. We're going to ask them, show me your teeth, give me a big smile. It's easy to assess with that if they have some asymmetrical movement to their mouth. So on our race assessment, either they're both symmetrical, so that is absent, or it's mildly, slightly asymmetrical, they would get a 1, or with Mr. Hernandez, his case, he would get a 2 because he has severe, completely asymmetrical movement of his face. Now we're going to go down and we're going to look at that arm function. We're going to ask the patient, extend your arms out. 90 degrees if we're sitting. If they're already laying on the cot, we're going to do 45 degrees. We like to have the palms up because it's physically harder to keep that arm up there. So we're going to see, are they able to hold that arm up for 10 seconds? Is there a little bit of drift, or are they completely unable to hold that up? They're going to get a 2 for that one because he is completely unable to hold that up. Now, I also like to ask my EMS providers, like, have you ever thought of why the patient can get their arm up, but they can't keep it up? Most of them pause at that point in time. So I'm going to ask that to you all. Why is that possible? We're going to come back to that as we continue to move on. We're going to look at the leg function next, and we're going to assume, once again, he's unable to hold both legs up against gravity. Now, here is where this tool becomes a little more sensitive for a large vessel occlusion. Going back to our case study, he had that gaze deviation present. Okay, so he is going to get a 1. Now we know with those gaze deviation present cases, that once again is given us a higher likelihood that they're having a large vessel occlusion. Going on down, we're going to kind of separate this into the right and the left hemisphere assessment. We know the impulse on the right hemisphere to close your eyes and make a fist comes from 2 different areas of the brain. So we're going to ask them to do both of those tasks. If they can, they would get a score of 0. If they can do one task correctly, they would get a score of 1. If they can do neither of those tasks, they would get a score of 2. Mr. Hernandez was able to do both of those. Now, he had a left gaze deviation, so we're more focused on that left hemisphere with Mr. Hernandez. What we're going to ask them to do, hey, I'm going to squeeze your arm. What am I doing? Well, I'm squeezing your right arm. I'm going to go over here and do the same thing on the left side. They might not be able to understand what that is or have that neglect of what that left hemisphere was. And we're going to come back to some of the agnosia and the neglect later on. So Mr. Hernandez is going to get a race score of 7. For EMS, anything over a 0 should indicate a stroke alert for their patient. And we're going to talk about what the stroke alert is in the EMS world coming up here in a little bit as well. And we also know anything over a 4 on their race assessment gives us a high index of suspicion for a large vessel occlusion. That might change where this patient is going to go for treatment. Now, we're not going to be successful or accurate on 100% of these cases. We're going to miss a few, but that's okay because we also don't want to miss the ones that we should be right on. You look at Mr. Hernandez, a 59-year-old gentleman, has many years worth of work available to him, probably has children, has grandkids on the way. You look at how affected his life would be if he's unable to communicate and he has that right deficit for prolonged periods. So we want to be more cautious on those. We want to get them to the correct location. We don't want to dismiss them as something else and delay that care long term and give them a worse outcome. And on the ones that were wrong, let's look at why we missed it. What could have done different? What signs we missed? Did the system let us down? What are ways that we can improve that care? So we want to circle back to those that we may be over triaged. Looking at our stroke specifically, almost 800,000 Americans every year have a stroke. It is a leading cause of death and disability. On average, 700,000 of those are having an ischemic stroke. So we know a large percentage of our population that we're dealing with acute stroke-like symptoms are going to be ischemic. And with those ischemic stroke patients, we have options. We have a medication we can give, and we have the endovascular therapy that we can administer as well. So we want to know if we can get those two treatment within that first 4.5 hours, we can make a difference on their outcome, as stroke is a leading preventable cause of disability. And we know that time is tissue, and the longer we delay in that definitive care and getting that blood restored, the worse their outcome is going to be. Do we miss them? Absolutely. Have there been some cases? Absolutely. Are they large financial cases? Absolutely. Here's an example that the jury awarded $11.5 million to a New Jersey woman who was misidentified as drunk during a stroke. Canadian police officers left an individual in a jail cell for 18 hours while suffering a stroke. And it's not just law enforcement. EMS misses them as well as signs of intoxication, delaying that care, causing a death down the road. So it does happen. These are the ones that we want to prevent from occurring by improving the system. As we look at strokes, we're going to consider two different types of stroke. Either they're a hemorrhagic stroke or they're an ischemic stroke. We also know that the larger percentage, 80, 85, 87%, are going to be ischemic strokes. And it varies where we take these patients based on their severity. When we look at the hemorrhagic stroke, once again, this is a lower percentage of our strokes. We know that we have 3 layers to our blood vessels. That first inside layer is smooth as glass. The blood is just flying through there uninhibited. Well, something happens to that layer. It gets a little fracture. It gets a little cut in there. And now we have an opening into that second layer, the muscles that make them bigger and smaller. Well, the blood starts to get in there, but it doesn't escape out into the body because there's a third layer that keeps it all together. So that blood and the tissue starts getting trapped in there, and that area starts to expand. That rupture starts to get wider on that inside layer, and eventually it bursts and it bleeds out into the brain. We have an aneurysm, it weakens, and finally it ruptures. Hypertension is the most likely reason for that, but hypertension is a 20-year killer. I can go to the physician today and my physical and says, hey, your blood pressure is pretty high. You should probably change that. Okay, I will do my diet, my exercise changes. I'll come back next year and it's like, hey, your blood pressure is still pretty high. I'm like, yeah, I probably didn't do the best job changing that. I'll do better next year. This can go on for many years. Eventually, though, 20 years down the road, it's going to catch you. It's going to cause a stroke. It's going to bleed out into the brain. And these are more deadly, more grave outcomes, less we can do for these patients. On the other hand, we have our ischemic strokes. Just like in our chest, when we start to have chest pain from an ischemic blockage there, we start to lose those muscle tissues of the heart. The same thing happens up into the brain. We have a clot that forms and lodges up in a narrowed area of our vessels. Now, the difference between a clot in the heart and a clot in the brain is the clots in the brains traveled there. They didn't form there. They traveled either in the heart, which from atrial fib, or from a post-surgical thing, or some other area, but these clots are more established and they just found that narrowest part of our brain and got lodged there. And once again, these are a larger percentage of our strokes. But these are the ones that we can treat because we can reverse that process. We can give the clot buster. We can go in and pull that clot out of there and restore that blood flow to that area of the brain. Now, I do have to admit, I've been doing EMS for 30 years and I had never heard the term penumbra until I started teaching this class. So we know that the penumbra is an area of salvageable tissue beyond that blood-starved infarct. And we also know that we can lose tens of thousands of brain cells every second that we do not have oxygen-rich, glucose-rich blood going to that brain. Now, we also know that our brain has a collateral circulation already built into it. So that area of penumbra is going to be fed by that collateral circulation or that collateral blood flow. However, that blood flow is not adequate to maintain that what needs to be going on. So we go back to our situation where, hey, I can raise my arm, but I can't keep it up. So let's imagine the stimulus to raise the arm is coming from right in this area of penumbra. So I have that collateral flow that's saying, hey, brain, raise my arm. I raise my arm, but I don't have enough blood there to keep that arm up. That's our outward sign of that area of salvageable tissue there. And we also know that time is critical on this. Time is tissue. Just like with the heart, time is tissue in the brain because it's not going to come back if we don't get blood flow restored to that area. We also look at our TIA or our transient ischemic attack, where we have that brief temporary lack of blood flow there. A lot of the times it's resolved by the time EMS gets there. It's kind of called a mini stroke, but it's a warning sign. For example, when I'm out teaching, if I'm up at the front of the class and I say, hey guys, I don't feel good, what's the first thing they're going to tell me? They're going to tell me, hey, you should sit down. If I tell them I still don't feel very good, they're going to tell you, let's lay you down. All right, now I'm down on the ground. Oh, hey, I feel fine. Let's keep going. Well, I had an area that wasn't getting oxygen-rich blood up there, and my brain's telling me, I don't feel good. You need to do something. Well, the heart can either increase fast or it can constrict the vessels to increase that pressure. I get laid down, all that stuff starts working, and blood starts going back to that area that was being affected, and now I feel fine. Something's going on. Something occurred to cause that. We need to still treat that as a medical emergency because that's a warning sign to us that another stroke is coming. And we also know that 1 in 4 strokes have had a previous stroke. So there is a high index of reoccurrence. So we're going to treat these as a medical emergency. Now, are they going to have a high RACE score? Will they go on immediately to endovascular? Probably not, but they need to be evaluated at a facility for further testing so they don't have a full stroke in the future. If you've taken any type of AHA course, you have seen these risk factors, the controllable and the non-controllable. We are unable to change our age. We're unable to change our family history. We're unable to change our race. These are things that can't be controlled. However, our controllable risk factors, we can control our blood pressure. We can control our cholesterol. We have seen that these strokes occur in the brain from a clot that gets lodged in a narrow area. The high cholesterol starts occluding our vessels and eventually it's going to catch us. All of these other things of the obesity and the heart disease and the atrial fib. We also know atrial fib, you're at 5 times higher increase risk of stroke from atrial fib. So these are all the things that as we're doing our assessments and you have some of these controllable risk factors and maybe you're in your 40s with stroke-like symptoms, but you have some of these risk factors involved, yeah, I'm going to treat you as a stroke because of all this other stuff that's going on. We also know that illicit drug use is giving us a younger population of strokes because of the effects on the body of these drugs. So you have a 20, 30-year-old with stroke-like symptoms, and through our assessments, like, yep, we have some recreational habits. I'm going to treat you as a stroke. Previously, we might not have considered these folks having a stroke. When we get into our female population, there's all kinds of things going on in their body. The birth control pills are putting them at an increased risk for stroke. Frequent migraines are putting them at an increased risk for stroke. The hormone replacement therapy, the clotting disorders, all of these are giving our female populations an increased risk for stroke. So in our EMS world, I get called out for a 26-year-old healthy appearing female that is having stroke-like symptoms. Previously, I might have dismissed this as not possible for this person to have a stroke, but it is. It is very possible because we have some of these underlying health factors that affect the female population that doesn't affect the male population. Now, we've talked about time as tissue. Time is very important. So we want to identify these strokes and we want to identify the intensity of these strokes. Now we look at our common signs and symptoms. We've all talked about the numbness or weakness in the face, the arms, or the legs, that confusion, the trouble speaking or understanding, the trouble seeing out of one or both eyes, trouble walking, the dizziness, the vertigo, the loss of balance and coordination, and then severe headaches from an unknown cause. The middle cerebral artery is the most common one occluded from an ischemic stroke. And that's the one that's going to give you these large global type symptoms. But we also have other symptoms. They could have some respiratory abnormalities. They could have the difficulty swallowing, and the nausea and the vomiting could be part of these symptoms. So we want to look at some of these symptoms and see how can we make a difference with what we've learned. How can we spread the awareness to others of stroke-like symptoms? And the other thing that I have found during my presentations is typically within 24 hours, these EMS folks are going to have a call for stroke-like symptoms. So with that being said, let's look at our easiest way to identify a stroke. FAST. Super simple. A new onset facial droop to the one side where your face either drops or feels numb. You have them smile, and if one side doesn't raise when you smile, that's the facial droop. You look at the arm weakness. Is one arm weak or numb? Are they having trouble holding a pen? Have them squeeze your finger and see if both of them are the same. Have them raise their arm, and once again, have the palms up because it's harder for us to physically maintain that, and see if one drifts downward. And then you look at the speech. Are they having any speech difficulty? Now, the speech might be slurred or they might have trouble getting the words out. So don't just think of speech difficulty as slurred speech. It could just be having trouble forming the words, or the words coming out are kind of garbled. So if you have any of those signs or symptoms, that's the time to call 911, because having these symptoms present is 80% of our strokes. And we also know a high percentage of our strokes are ischemic strokes. That's a high percentage of people that can be treated if we do it quickly. Now, to get a little more specific, we talked about the balance and the vision, where the BEFAST acronym comes into play. We're looking for that new onset loss of balance, the new onset eye changes, the vision changes. That posterior circulation accounts for 40% of acute ischemic strokes, and they're going to present with your balance and your vision changes in that posterior circulation. Because when we look at the areas that can be affected, once again, the balance in the eye is that posterior circulation of that occipital lobe. Your face and your arm is in that frontal lobe, the back of that frontal lobe, of that motor cortex. And then we look at the speech. We can either have an area that's affected the Broca's area or the Wernicke's area. We have the muscles of speech of getting the words out, and we have the words and how the language is comprehended and the words that are coming out. We have two different areas that control that. And once again, time is critical on these patients. Let's call 911. So when we looked at that previous slide, looking at our frontal cortex in our different hemispheres, we have a large frontal lobe. That's why those common signs and symptoms are those motor, the arm drift, the facial drift, because all of that is controlled up. A lot of that is controlled up in that frontal lobe, the biggest area of our brain. And then we kind of look back at that occipital region with our balance and our vision back here in the back. And then these other areas, that Broca's area and the Wernicke's area, is kind of buried back in those hemispheres. Once again, that's the muscles of the speech and how the words come out. Back to our common signs and symptoms. as we look at our hemispheres, they're not exactly the same. Once again, they don't control the same thing. So when we talk about the right-sided stroke, we're going to have the left-sided deficit or the left-sided neglect. A right-sided ischemic, they're unable to hold up that left arm. When you look at that gaze, we talked about how that gaze is indicative of an ischemic stroke. That right gaze is if they're affected on the right hemisphere. Now, you look at the speech differences between the right and the left hemisphere. The right hemispheric strokes are slurred. The left hemispheric strokes are unable to get the words out, or they might come out garbled. So that's another indication of which side of the brain is being affected. Obviously, as you get deeper into the brain, we know the big vital functions are hidden and protected back down by the brain stem. But these are going to give you nausea and vomiting, the speech, the swallowing problems, and they're going to give you cross findings. A brainstem stroke might have right arm deficit and left leg deficit, and the gaze would be completely different. We talked early on about the hemorrhagic versus the ischemic. I still want to cover because 13-ish% of our strokes are hemorrhagic. Now, with a hemorrhagic stroke, they're either going to bleed into the functional area of the brain, and you're going to get the one-sided effect from that, the one-sided weakness, as well as the nausea and vomiting and the headaches and the decreased consciousness. Or it could be bleeding around the shell, pushing down on the brain. These folks are going to present with the worst headache of their life, the sudden onset of the thunderclap type headache, a very intense, very painful. They're also going to be intolerant to light and have that neck stiffness and pain with those subarachnoid hemorrhages. This is an example of that agnosia or that neglect. When I talked about the right and the left hemisphere, hey, what am I doing here? You're squeezing my right arm. Hey, what am I doing here? I don't know what you're doing there. I don't know whose arm this is.
How when you teach a child to cross the street, what do you tell them to do? Before they cross the street, what do they do?
You gotta look both ways.
Look both ways, exactly. So with any activity, what I want you to do is I want you to practice looking both ways before you start any activity, okay? So look to your right first, and then look over to your left. Perfect.
Now you notice
Now,
he
I'll come
stops
over here.
mid-line.
I want
That's
you to
an
look,
example. He
look
does
to the
not
right, I want you to look
understand
over
that
at
that
that
left
room over
world
there.
is part of
And then
his
when you
world.
look to the left, I want you to look over here at me, okay? So look over the broom, and then look over at me. And follow my hand all the way out here. Beautiful.
And he has to
And then
physically
right.
turn his
Okay.
head all the way
So
to the left. So that would be an example where I'm squeezing this arm. Yeah, I know you're squeezing my right arm. I'm squeezing this arm. He's like, I don't know what that is, or I have no idea whose arm that is.
how when you
Oops.
teach a child.
Now, when we talked about the speech patterns, we talked about the muscles of speech and the formation of this speech.
Hi, Byron. How are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talked with the people for them over there. They're diving for them at the moment. They'll save in the moment. He'll have water very soon for him.
So Byron has had a stroke that affected
So we're
his
on a cruise
Wernicke's
and we're gonna
area
We
teach
of
will
him
his
to
store it
do.
brain.
right here and they'll save
He
the
has
hands
no
right
idea
there
that
for
his
them.
answers
And what
to
were we
his
just doing
to
with the
those
iPad?
questions do not match
Right
the
at the
questions that are
moment,
going
don't
on.
show a darn thing.
With the iPad that we were doing. Like here?
So he does
I
believe that
might
his
change
answers
for
are
me and
accurate
change hands.
and would not understand. So it'd be difficult to assess this patient, right? It kind of mimics a dementia type patient, but this was actually affecting the Wernicke's area of his brain that interrupted his interpretation of the language. And now we look at the Broca's aphasia.
Well, a very, very heavy debatation tonight. We had a very Darrison, but let's go to Terrace and look for the head of the pit.
Now you look at an individual like that, healthy appearing mid-20s female with no obvious signs of massive trauma, cardiac event, complicated delivery. What other time critical condition? Unfortunately, this is a stroke as well. And this would be one that'd be very easy to dismiss as either intoxicated or on some other type of substance. You also look at her eyes, she understands that what is coming out does not match what she's trying to say. And can you imagine the panic that would start to set in and how this would increase blood pressure, increase heart rate, and only make those stroke symptoms even worse as we go down? Because she is fully aware that something is not right.
First time, Sari.
Now, looking at our last known well and symptom onset. This is a very important concept that we talk about in our EMS that we want to establish. And this is what EMS can really help establish for this patient. The last known well is a time that this patient was symptom free. And we're going to do everything we can to obtain an accurate time on this patient, because this is going to dictate what happens to them down the course of their treatment. So they would be a reliable source. They might not be. We might need to rely on family or other providers that was in the area. And we're going to talk about the bedtime when they wake up from a stroke-like symptoms here in just a minute. But the biggest thing I really get across to our EMS providers is we need to make this an actual time that they occurred. It's very common for us when we ask how long has this been going on, the family could say, about an hour ago this started. All right, we do our thing. We put them in the ambulance. We're doing a 30-minute transport to the hospital. If we give a radio report and says, hey, onset of symptoms was about an hour ago, now we get them into the ER, they get bedded, the physician comes in, starts asking questions, and the nurse relays the information we gave them, symptom onset of about an hour ago. Well, actually, now that was 2 hours ago. We really want to focus on converting that to an actual time versus minutes ago, hours ago. Let's look at last known well versus symptom onset, because once again, I'm going to start including the time frame in here. We know with our TPA, T&K, we have 4.5 hours from symptom onset. However, what if we get called out for a situation like this, that they woke up with stroke-like symptoms? Patient went to bed about 10 o'clock, woke up the next morning at 6 a.m. with stroke-like symptoms, 911 was called. What do we know? Well, the last known well was 10 o'clock the night before. We don't know the symptom onset. Could have happened anytime during that case. Right now, that patient is at 8 hours from last known well. Through our investigation and through asking questions like, hey, what happened with this, folks? Did they wake up at all during the night and say anything? It's like, oh yeah, at 5 o'clock, he got up and says, gosh, I have a heck of a headache. I got to go to the bathroom. I'm going to lay back down and sleep for a little while. Well, at 6 o'clock, he has stroke-like symptoms. Well, all of a sudden now we've changed it from an 8-hour onset to a 1-hour last known well at 5 a.m. Makes all the difference in the world for the treatment of these patients. We talked about early on, stroke is largely treatable. If we can respond quickly and get them into our system quickly, we can make a huge difference in the impact of their long-term care, because we also know that if we can get that blood flow restored within the first 2.5 hours of event, they can come out of there with very minimal deficit. So that's why our treatment is very time dependent. We look at our 4.5 and our 24-hour window. So when we're looking at those, where do we take these patients? The AHA different hospital levels for the stroke includes our acute stroke ready hospitals as the base layer of our care. Here in Iowa, those are our critical access facilities. They have CT capabilities, they have a physician on duty, and they have thrombolytic capabilities. The difference between an acute stroke-ready hospital and a primary stroke center is the primary stroke center will keep some of these patients and treat them long-term. The acute stroke-ready facility is going to transfer these patients on for further care. But the primary stroke center is not able to do the endovascular therapy. You need to go to a thrombectomy stroke capable facility to do the endovascular therapy, or onto a comprehensive stroke center. In Iowa, we only have one endovascular capable facility, that's Mercy in Des Moines, and our comprehensive stroke center that can do everything is at the University of Iowa in Iowa City. If we take our triangle and we throw it into a box and we add some other pretty colors to it, you can see our comprehensive stroke center, all of their capabilities on the right-hand side versus our critical access facilities are our rural facilities on the left-hand side and the limited capabilities they have. So when we look at where to take this patient, we need to determine where are we at in our last known well, our symptom onset time frame, and how close are we to a facility that can administer TPA or TNK. If we're within that first 4.5 hours, we want to get them to someplace that can administer that medication. Now, are we within 60 minutes of a comprehensive or a thrombectomy capable? If we are, and we have a high race score, maybe we're better off taking them directly to that facility that can administer that. Or are we outside our 4.5 hour window, but we're within our 24-hour window? Maybe our best choice is taking them directly to a thrombectomy capable or comprehensive stroke center. In Iowa, this is what our map looks like. So the shaded areas are the distances from that. So you see the red circles there. Those are the LVO treatment capable facilities. So Mercy and Des Moines can do the endovascular, as well as the University of Iowa can do the endovascular therapy. If you get over into the western portions of Iowa, there's a couple options in the Omaha area to do endovascular, and you get up north into the northwest region, Sanford and Avera up in Sioux Falls can do the endovascular area. All of the green triangles are our primary stroke centers and the 60-minute drive from those facilities. Well, that leaves a lot of the state outside of that area. You also get up into the northern regions there where they might be transferring these patients up to Rochester or the Twin Cities or over to La Crosse, Wisconsin to do the endovascular capabilities. We go back to our state of Iowa, we add a helicopter to the mix. Now you can fly everybody within an hour to an endovascular capable facility. It might not be within the state, but you're within an hour for just about all the entire state. So this is where we come into the conversation of, hey, will we fly a stroke patient directly from the scene? Back when I started EMS, that wasn't even a consideration. The only thing we ever flew was major traumas. Now, that brings us into a conversation like, hey, I might need to fly my stroke patient directly from the scene to an endovascular capable facility. So what care are the folks going to do on scene? We're going to monitor their airway, their breathing, and circulation. We're going to give them some oxygen if they need that. And here's where we start looking at our stroke checklist. We go down the race checklist so we can identify the severity of this patient. We're going to also establish and record that exact last known well or symptom onset because we know that guides the care down the road. We're also going to talk about witnesses and family members. We know in the hospital they're going to have a lot more questions for this patient because there's a lot more to become. So we want to talk to the family members like, hey, if you're not going to come with you, make sure your cell phone is turned on, make sure your ringer is turned up, and make sure you answer a call from possibly an unknown number because it might come in from an unknown number and it might be the hospital calling and says, hey, we need more information. And then we're also going to obtain all of their medical history, the medications, also any recent illnesses, surgeries, any history of stroke, because once again, we know they can have repeat strokes. With Mr. Hernandez, they decided that this patient needed to go to the local facility where they could give the thrombolytics. With that, they did a CT. They want to have a CT available. They want to have the physician there. They want to have pharmacy there. So they gave a stroke alert. That should activate the system within the hospital that says, hey, we need to call in CT. We need to have the physician available, and let's bring pharmacy in so they're ready to administer the TPA or TNK quickly so we can start that blood flow back. And we also know if we're going to take them to an acute stroke ready hospital, that individual is going to need to go on for further care. So we might need to be making some arrangements for an interfacility transfer. As we're heading to the hospital, we call them in, we let them know we're going to maintain oxygen greater than 94%. Blood pressure, we're going to monitor that. We're going to not treat the hypertension, but we're going to trend the hypertension. A lot of times we'll throw a monitor on and grab an automatic blood pressure. Hey, that's showing high. Let's grab one on the opposite side. Let's do a manual blood pressure just to confirm. Because we know that the brain is trying to perfuse that ischemic area. The only way the brain can change that is to push harder and push faster. That's why our blood pressure is elevated because there's a part of our brain not getting oxygen-rich blood. And obviously, we want to record and assess for hypoglycemia because I will also promise you any provider has missed a hypoglycemic patient and treated them as a stroke at least one time in their career. And if they tell you they haven't, either they haven't seen enough stroke patients or their partner has covered for them and caught it for them. We also want to look at their cardiac function in our stroke because we know AFib causes strokes, puts them at a higher likelihood for stroke. So if we find atrial fib on the monitor, that's golden for the patient because that's going to be something that they're going to be cared for and treated for down the road. Also, if they're a BLS service, we're going to intercept with an ALS, advanced life support, and report this information on to our hospitals. There are barriers to our care because we do know that strokes are a very small percentage of our care. Less than 1% are acute ischemic stroke. So anything that we don't do frequently are things that we don't do our best. So that's why we're trying to do our follow-up care. We also know that there's lack of formalized follow-up on these patients. We get great information on our STEMI patients. We don't necessarily get the same follow-up on our stroke patients. That is something that is being worked on through this process, and we're trying to improve that on the hospital side. We also know that EMS resources are very limited here in our state, especially for inter-facility transfers on these acute care facilities. So the faster we can be preparing for that, the better off we are. And we also know that people don't call 911 right away. They dismiss it, or these symptoms might go away. We need to really increase our public awareness on that. And we also have a ton of different stroke mimics. We know hypoglycemia mimics a stroke. We know sepsis mimics a stroke. So there's all these other things that could delay that care, thinking it's one of these and not an acute ischemic event. Like we talked about early on, EMS helps, EMS works. There have been studies that show people that are calling 911, starting their stroke care by EMS, have a decreased endovascular time. They get to the appropriate facility faster. They have decreased door to needle times, and they have better 90-day outcomes. We also know every hour of delay in endovascular therapy, their functional independence diminishes by almost 4%. So every hour of delay is worse for these patients. And we also know that if we're doing better on the EMS side, the hospital side is going to have better outcomes as well, because we're going to have better door to physician times. As we did a stroke alert, the physician met us there. We're going to have improved CT times and better thrombolytic rates. Looking at our stroke, we need to rule out the bleed. This is very important. If these stroke patients are being brought in and bedded in the ER and then transferred to the CT, or even waiting for the CT tech to come in, that's delay. We love to have a stroke hotspot for these patients. They should go straight from the ambulance past the physician right to the CT scanner on the EMS cot. Because that's the quickest way, because we can get a CT done within 20 minutes if EMS is letting everybody know and the hospital system is spinning up for that. As we look at our different treatment options, we talked about the IV medications of the TPA or TNK up to that 4.5-hour window, and our medical thrombectomy up to 24 hours from symptom onset. Now, this kind of started in the mid to late 90s. It started off with a 3-hour from symptom onset. Currently, we're at 4.5 hours. It's a standard of care for our acute ischemic stroke. We know that by getting this medication on board, it's going to limit the damage to that area. It's going to restore the blood flow to that penumbra. We also know there's all kinds of other criteria that goes into this medication administration. For EMS purposes, if they have major neurological deficit, they are greater than 18 years of age, and they have less than 4.5 hours from symptom onset. For our purposes, EMS, they are included as eligible for TPA TNK. But like I said, there's all kinds of things that will make them ineligible for that. So that's also why we don't want to delay care thinking they're going to get the shot at the hospital and then they don't. And now we have to transfer them on for endovascular because that's their only option. Once again, time is tissue on these patients. So what is the endovascular therapy? Well, that's the mechanical thrombectomy, where we're going to go in and remove that clot and restore that blood flow to that area of penumbra. Now, I'm not here to teach you how to read a CT, but I can show you where the red arrow is at, right there, pointing at that ischemic area. And then you look back at all of this decreased perfusion in that hemisphere related from that clot. So for example, this is my stimulus to raise my arm. I have enough blood flow to get that there. I don't have enough blood flow to keep that up. So what happens during the endovascular is we're going to go in and grab that clot and restore all of this blood flow to that tissue.
So we place a large catheter in the carotid artery within the neck, and through that we advance a small micro wire that goes up through the blood vessels. It comes up to the point of the occlusion where the clot is, and it passes through the occlusion point into the normal vessel beyond it. Over the tiny wire we advance a very small catheter. It passes through the blood clot, and then we take the wire out. We usually inject a little bit of contrast beyond the tip of the catheter to ensure that we're still in a blood vessel, because remember, we can't quite see this on an angiogram. And then we advance the stent retriever, and just by pulling back the catheter, the stent widens and deploys itself in the blood vessel. It engages with the clot and allows some immediate restoration of blood supply. Sometimes we inflate a balloon in the neck to stop blood flowing and washing the clot off, but we pull back the stent, which has now engaged the clot, and it pulls and comes back into the catheter in the neck, and then we remove it altogether from the body. And if at first the clot doesn't come out fully, then we go in again with further passes.
And once again, that is a new opportunity that is available for our patients, and new within the last several years. And how they can go from the wrist, the groin, the neck, and get to the brain and the heart without messing things up along the way, I don't understand that, but that's why I'm here teaching EMS. But this is what we're really trying to get the message out to our EMS providers that's available to their patients that wasn't that many years ago. Looking back at our Mr. Hernandez, we arrived at the local stroke-ready hospital. He was evaluated on EMS by the doctor and sent directly to CT. The head CT was normal, which meant it was not a hemorrhagic stroke. They administered the thrombolytics, prepared him for a transfer to a comprehensive stroke center. Once they arrived there, they were able to pull that large thrombus out from his internal carotid artery, and within 24 hours only had mild deficit. You look back at a 59-year-old gentleman, probably has kids, might have grandkids on the way, has years worth of work left in him. And you go from a slump to the right side, having speech difficulty, to fully functional. The financial impact to them, to his family, to his community, to his employment is huge. That's why stroke is such a treatable condition now, because we have better options available for our patients. One more case I want to look at here real quick before we wrap this up.
Okay, are you going to fall? Do you need help? Are you hurt?
The victim is having
Okay, what's hurting?
and appendix.
You what?
Joining him in the request for exhumation was his son Todd, who by this time was 16 years old.
Are you diabetic?
No.
No? Okay. All right. Okay.
Can I just
I want to know what you took today. How much?
I don't know.
You don't know. A concussion or any injury involving your head?
Yes.
Okay. What injury is that?
Well, I have
I'm sorry. What did you say?
I don't have.
You don't. You have not. No injuries to your head.
I have trust class.
Now, this is a great example because we have actual
Okay. Are you going to fall? Do you need help?
have actual camera footage of the presentation that EMS or law enforcement might get on this individual. So Pat, we know, was at a Kiwanis meeting. She left about 1:15 to go get groceries. The law enforcement was called out for a car in a snowbank of a physician's office with a possible intoxicated individual. Around that same time, her husband has been trying to find Pat and is unable to get a hold of her because she's not answering her phone. So he calls the law enforcement and says, "Hey, I have a problem. I can't find her." About a half hour later, they put two and two together that the officers are out with her and are going to be taking her down to the police station. Through further conversation, he's like, "Hey, I think she's having a stroke and is not intoxicated like the initial call was." They rapidly realize that, hey, this is not right. They call for an ambulance. She's taken to the local facility, then flown out to a thrombectomy capable facility. So as we look back at the times, her last known well was at 1:15. EMS got involved at 4.5 hours. It's an unfortunate situation, but this is just a prime example of what we're dealing with out in the public, and how we can unintentionally put ourselves into a box. And the officer was called out for a possible intoxicated individual. She gave all of the signs that would mimic intoxication. He asked her if she was diabetic. She answered clearly no, but you have all of those other confusing words in there. It's unfortunate that her care was delayed, not necessarily the fault of law enforcement. It took a while for anybody to find her, but she now does have some deficit. I've talked to this family, and it's unfortunate that that has occurred because she is a repeat stroke patient, and it just presented that way. So that's why time is very important, and how these patients might not present with the typical facial droop, arm drift, speech difficulties. She only had the speech difficulties, and you could see when she was standing up, she was very unsteady on her feet. So in summary here, the stroke is a very time critical condition. We have better options for these patients, but we need to get involved early and get them to the appropriate destination. And that's where 911 comes into play. That's where EMS comes into play, because if we can get these symptoms resolved within the first hour or two, they're going to come out of this with very minimal deficit. And that's where we're really out working with the EMS folks, trying to get the systems better to get these patients to their appropriate stroke center to improve their outcomes. I thank you for your guys' time. If you're in Iowa and you know of EMS services that would be interested in this presentation, once again, this is free of charge through the Helmsley Charitable Trust and through the Mission Lifeline grant. However, the grant does end at the end of June. So please take a picture of that. You can either register with that QR code, or you can email me directly or give me a call, and we'll get set up with you and get that information out. So I am actively going out to, I think I have about 60 different services that we're hitting here over the next couple of months, and there's several of us out doing that. So if this Mission Lifeline is also coming to your state, please pay attention to it, because we're going to do the same type of effort throughout there. So if anybody has any questions, and once again, I'd be happy to share this presentation with you. I did see that in there. Shoot me off an email and I will send it to you.
Thank you so much, Matt. That was a wonderful presentation. In addition to the request for the PowerPoint, I do see a question real quick from Rebecca. She said, is it possible for someone to have stroke symptoms slowly, say over the span of a week, where they notice small things before realizing something more serious is going on?
So that is possible. This presentation is geared toward the acute ischemic stroke, where they had a massive blockage that occurred. It depends on all those vessels. They could get a clot in a small area of the brain that's being fed by the collateral circulation and only have mild symptoms. That's a great presentation, because we get that quite often. It's like, gosh, I think the symptoms would go away. What we tell folks is, if you have any major symptoms that come on suddenly that are not like past symptoms, this headache is so much more severe and so much worse than my past one, you need to be calling 911 and getting treated.
Great. Thank you, Matt. I see a lot of compliments in the chat box. Any other questions, folks, before we sign off for today?
And I do see a question in there about YouTube that Janice sent me, and we are working with community college here to put this presentation together as a full video series. That'll be coming out probably later this summer. I will get a hold of you, Courtney, and send this information out once we have that available. But yes, we are getting this put together to have on YouTube available for everybody.
Wonderful. And we will subsequently upload this recording to our YouTube page, probably sometime late today. I think that's everything, Matt. Thank you again. Very informative, always timely. We really appreciate your time and sharing your expertise with us today.
Absolutely. It's been my pleasure.
Thank you so much. And thank you everyone for attending. Have a really good afternoon.